I'm trying to focus on connecting some of the legal and ethical questions that we've raised here with my colleague Michael Stein with some of the more practical issues that happen in the clinic. So I ask you to imagine what happened after the civil rights laws were passed. Desegregation didn't exactly happen in concordance with the legal and policy changes. Something had to happen in the culture of the country as well. In the same way that a hospital is a culture of some ways, I'm focused here on the social science of stigma and discrimination and how that might need to be incorporated into our understanding of how doctors and patients and clinicians interact. This is really open territory. The study of discrimination and stigma hasn't really focused on disability yet as much as other categories. So, as we know, persons with disability face huge disparities in outcomes, and it's only recently being documented. But the question is, how do we solve this? If you look at some of the proposals, a lot of emphasis on legal and policy proposals, improved access to services, decision support services, increasing workforce capacity, inclusion of disability in public health programs, emergency preparedness, all wonderful things. But something's missing in this. So imagine this gentleman goes to the hospital, but things don't change. Just like desegregation doesn't really happen overnight, you still see these unequal outcomes despite all these policy changes. So I think what's missing is the social and psychological causes of the same problems. I think it's really in this box that we overlook what's happening between caregivers and patients. And so I'll be putting some attention to that. So specifically, the question is, it would be wonderful if we somehow could characterize this systematically in the same way that we do for other variables where there's disparities. What actually happens between a clinician and a patient with a disability that produces or contributes to these outcomes? So here I'll be trying to connect the social scientific study of prejudice and discrimination with the lived experiences of persons with disability in clinical context. Because of course the hospital isn't a magical wall that somehow takes all the social forces outside of the hospital and makes them different. There's a lot of similarities. And so can we characterize some of the systematic biases and then describe how we can change the way people make decisions based on those biases? That's a good anthropological, psychological project. And then translate that into how you might want to study the question so as to prevent further harm. So that's an outline. So the legal and bioethical standards we know are clear and well articulated: non-discrimination, reasonable accommodations, trying to characterize some of what the psychological foundations are for informed consent. The Rehabilitation Act of 1973 and the ADA, of course, paramount in this regard. But not dilating on that too much here, trying to connect that to the social forces and psychological biases that we see. How can we actually connect how clinical decision-making happens? So it's a huge topic. So we can only focus here on a few of these, pick 3 biases in particular. But what do you look for in how clinical decision-making gets biased? It's like a spray of altered propensities between the clinician and the interactions get changed in subtle ways. So overall, you could say you don't hear frank animosity. You hear more or glorification, but something more like paternalism, projection, pity, low expectations, infantilization, catastrophizing, all with good intentions. So how do we take that sort of gut instinct we have about what we see in a clinic, formalize it, and try to prevent it? We would focus on how do diagnoses change? Do they become more severe or less severe than they normally would be on objective criteria? How does treatment planning change? How do prognoses get given or diminished, shrunken? Prevention, when is prevention the main issue at hand and when is it an afterthought? Cost considerations, when does the accountant come knock all of a sudden in some situations more than others? And when do, it seems fluffy, but hope is such a huge thing in the clinic. I'm a physician as well as social scientist. I see hope as concretely as a pill, end-of-life decision-making, and the therapeutic alliance, which we know predicts so much of clinical outcomes. And first of all, clarification, whenever we talk about bias, we always are concerned about accuracy. So the clinician's job is to accurately understand where the patient is at a given point in time, sensitively observing and listening. And we think of bias as something where there's a systematic pattern of inaccuracy in mental state attribution or decision making. So there's a slanted, systematic way of misunderstanding the person before us. So great cases are examples mentioned already: suicidal projections on the part of the clinician onto the patient, or catastrophizing about what somebody would want in a certain state. So the first one I'll talk about is something you hear often in narratives, and I always start with the narratives of experiences of people with disabilities. For the perception of being low in agency or competence, and what perceivers often do, extrapolate from a narrow marker of difference or disability to the whole person and their entire mental state. This is probably one of the most common things. And the question is then, how does that go into the clinic? What happens in the clinic? You can imagine if someone is perceived to be lower on agency and competence, there's going to be more paternalism. So in giving a diagnosis, paternalism will probably, because the patient's experiences are considered less reliable, the quality of the diagnosis will go down. Collateral sources will be more important in the diagnostic formulation rather than the experiences of the patient themselves. The other thing that's interesting, if the locus of control for what's happening in front of the clinician is paternalistically framed, the clinician will also discount poor self-care and self-destructiveness on the part of the patient. You'll see less of an emphasis on data gathering in that way. In terms of, again, it's less based on the patient's preferences because they're unreliable in some way. There's not joint decision-making. You may also get more conservative treatment recommendations. The patient's presumed to be a little less able to comply with complex treatments. We're not going to go for the Hail Mary treatment. We're going to go for something that this person can handle. Prevention, obviously more neglected, maybe more oriented to the social supports, not the patient themselves. Caregivers, group homes, and practices when the experiences of the person themselves really should be paramount. Prognosis will be more pessimistic. Maybe the interests of the hospital or the convenience of the doctor, the running of the clinic will outweigh the goals of the patient at the end of life in terms of cost saving. Patients will be less impacted with less joint decision making, less self-care, and of course there's less therapeutic alliance. So that's like a picture. You can imagine walk into a room, into a clinic, and you see what's going on here really outside of what's being said. This is maybe what's going on. Now, second bias, fragile friendliness, and these are nomenclature. There's a perception of the other being higher on capacities for prosocial warmth, prosociality, and trustworthiness, so friendliness, combined with a perception of the other being higher in the capacity for subjective experience. This comes out of the cognitive neuroscience and social psychology of perceiving other minds, and we see this in other situations. But fragility and friendliness combined to produce this specific kind of bias. And the two clinical outcomes are a kind of clinical saintliness bias in decision-making, as well as fragility bias. What does this mean? So the fragility would be the diagnosis, there's one dimension. The diagnosis may be overestimated in its severity, overdiagnosis, overtesting. In treatment, imagine if one is overperceived as fragile, less conservative treatment may be recommended. Prognosis, one would underestimate resilience in the patient, and suicidal projections will be put onto the patient, or hopelessness at the end of life. Saintliness is a little more interesting and probably more counterintuitive. So imagine if you listen to people's narratives, you hear often, I'm allowed to not really be a regular person. What does that mean? Sure. Maybe there's certain ways in which my positive emotions are underestimated, but also is a patient allowed to have anger management problems, self-injury, impulsivity, substance use disorders, sexually transmitted diseases, homicidality, personality disorders, marriage infidelity, hopelessness, lack of courage, pettiness. These are all things that happen to people. So if this is denied in some ways, the clinician and the patient's interaction will be systematically distorted. So the doctor will underestimate, through the patient being saintly, all the ways in which the dark parts of human nature contribute to clinical outcomes. The diagnosis will not really waver from the saintly script. Antisocial, self-destructive things that should be looked for will be overlooked. Prognosis may be optimistic and overestimated. Treatment would assume, oh, you never not adhere to your medicines because you're such a, good saintly type of person, and maybe we shouldn't check for that. Maybe we won't ask about it. Therapeutic alliance will be shifted, not necessarily denied, but these dark parts of human nature won't be a part of the conversation. Finally, a catastrophe bias, which is probably what we've heard from today, overestimating suffering and hopelessness, wanting to die than the person actually experiences, whether at a given temporal moment in their life or in general. Underestimating resilience and adaptation and growth. There's a lot of good studies on spinal cord injury, amputation, terminal cancer. This is well documented. What happens in the clinic? You see more severe diagnosis for the same presentation factually. Treatment being more conservative, because if the prognostic pessimism is high, one isn't going to have good expectations. Preventative measures, why would you want too many preventative measures? Things are so hopeless right now. Cost considerations, the accountant comes knocking again, wants to know about the budget. Patient hope obviously goes down. Nocebo effects are elevated, the opposite of a placebo effect. And also the clinician's hope is diminished. And when the clinician's hope is diminished, that'll change the way interactions happen and things that are suggested, things that are fought for. And then in the same way, you have more suicidal projections onto the patient. Also interesting, the requirement of mourning. There's this kind of implicit requirement of mourning. You must be suffering. You must be miserable. And it's more about the clinician's need to help overriding patient's actual situation, where they are at. So you have this distorted therapeutic alliance. So this is a summary of what I've talked about here. Now, What about interventions? I see interventions primarily as educational and clinical, which need a lot of research, just like medication intervention. So consciousness raising, making these biases known. Of course, this is not ever talked about in any clinical educational environment, really. Case studies should include actual patients with disabilities, not abstractions and hypothetical humanoids in thought experiments that we would never meet in the clinic. Clinical formulations, currently when you present patients, it's not really, the whole issue of bias is never a part of the formulation at all, much less related to disability. Increasing contact with people has been a great source of demonstrated evidence of decreasing these kinds of biases outside of the disability context as well as within it. Accepting qualified persons with disabilities as clinical students, as well as peer educators, and integrating disabled persons as faculty and community-based teachers. The other thing that these biases get worse as people get more training, which is paradoxical. But not if you understand the biases, because people are the nicest you'll ever meet them in clinical school on day one. Then they get worse and worse as they get more clinical experience. So these need to be lifelong, and they need to go beyond the doctors, because let's be honest, the doctors don't do much of the direct caregiving in proportion to other people. So thank you very much.